I got to remember what I said. So we're going to be talking about sexual and physical abuse evaluations at a Child and Youth Advocacy Center. You have the bios, I suppose, of both Dr. Amy Ornstein and myself. I'm a nurse practitioner at CYAC. I'm going to spend the first bit of the webinar talking about just generally about medical evaluations at a Child and Youth Advocacy Center, and then Amy will speak about the sexual abuse cases that may come across your center and how to sort of navigate in terms of having a medical provider and what medical issues may come across the CYAC in terms of sorting these cases out in more detail. And then Amy's going to talk about physical abuse cases that may come across. I think the first thing that we need to sort of put forth, obviously Amy and I both come from tertiary hospitals where we both see a fair high volume of cases, recognizing that a lot of people who are listening to this webinar maybe come from smaller communities where access to a nurse practitioner or a pediatrician who are experts or specialize in child maltreatment may not always be available. So we will talk about that throughout the webinar as well. So the NCAC, which is the National Children's Alliance and the National Child Advocacy Centers, which is a body in the U.S. that has set out standards for accreditation for CACs, does have one sort of element to it that speaks to medical evaluation. And the standard is that specialized medical evaluation and treatment services are available to all CAC clients and are coordinated as part of the multidisciplinary team response to CACs. There hasn't been a lot of studies looking at the medical component of a CAC, but a study done by Walsh in 2007 found when they compared CACs to non-CAC communities, what they did find is that more children had access to medical evaluations through a CAC. So certainly the access piece and being part of the multidisciplinary team is obviously a key piece. It's obviously going to be important as you are in perhaps the early stages of development from a CAC or doing a needs assessment, or maybe even you have a CAC up and running, to be aware of what services are available to you in your community. Many CACs don't even have medical providers located at their CAC, but they also may have partners who have been identified in their community in the CAC or with a CAC. And so I think it's going to vary from community to community as to how medical providers will be linked up. The other piece to be aware of is the kinds of cases your CAC is going to be seeing. So for instance, in Toronto, we typically service and the investigations are focused on severe types of sexual abuse, physical abuse, and neglect. And that may not be the specific population that you may see in your community. Our definition of investigations that come through the CYAC is really based on resources and the volume, so for Toronto specifically. Therefore, you may be open and may be talking about providing much more services for not immediate cases of child physical and sexual abuse. Certainly in sexual abuse cases, though, we do offer medical evaluations for kids when a disclosure may be sort of immediate, but the actual event may have happened a while ago, and I'm going to go into that a little bit later. So again, sort of this slide speaks to the fact that not all CACs will have sort of a formal medical clinic co-located at their CAC. Again, it's really dependent on the community, but it's also really dependent on who the medical providers are in your community. So you may not necessarily have a child maltreatment expert, but you may have a pediatrician or a family doc or a nurse practitioner who has been willing to at least provide some initial assessments for kids who may come through the CAC. So it's really going to vary. Obviously, you should try and obtain a partnership with a medical provider in your community who maybe initially can act as a consultant, may help to triage cases, who may help to be some sort of a gateway into various medical services in your community, and who could also provide direct service. But I find that the consulting role and the triaging role can be just as valuable than having someone sort of embedded in your CAC. You may also be linked to a hospital-based service. So for those of you in Ontario that I could speak to and have sexual assault, domestic violence, hospital-based services, you may want to link with those services directly, as they will have nurses and physicians who have extra training, in particular in sexual abuse, who could link with your CAC. And that may be relevant in other provinces as well. Again, linking with a practitioner in the community is really going to be your first step as someone who could take on these cases and play a role in your multidisciplinary team. So the different medical services that could be provided at a CAC are going to vary, again, depending on the location, where you're at, who are the providers in your community, and the needs in your community. And primarily, the role of medical services has focused mainly on physical and sexual abuse cases. And there's various roles that a medical provider can play. So as I spoke about earlier, consultations regarding the need and timing for an exam. This I find is pretty critical, especially in working with investigators, because one of the issues is many police and child protection services feel that the moment a child discloses something, they should be rushed to the local emergency department, when in fact the majority of those cases don't require immediate medical intervention, but they certainly require some form of consultation with a medical provider to determine what and if the child has injury, and when and who that child should be seen by. And so having a medical provider to provide this form of consultation would be really key. Some CACs will also provide medical assessments for kids who have been taken into care by the Child Welfare Agency as a result of the investigation. Again, this is going to be dependent on the medical provider, the need by the Child Welfare Agency, and whether or not this is reasonable to provide at a child advocacy center. It should be noted that a lot of child advocacy centers, in fact, most of them, other than Amy's, which is a hospital-based child advocacy center, really don't have full-time clinicians who are sitting at a child advocacy center. This would be pretty rare, probably because of volume and the, are there enough resources or enough cases to staff a full-time medical provider at a CIC, I think is pretty rare. So in a lot of the bigger cities, myself, Calgary, Edmonton, they have strong links with their child protection team and will link with the hospital-based child protection team on cases to determine whether kids can be seen at the CAC or at a hospital. So I know many people do try, when they're starting to think about their CAC and build their CAC, they're focused on having a medical clinic embedded at the CAC with the thought that they would have regular staffing of a medical provider at the CAC, and that's not necessarily always what's going to happen. And so just to be aware of that process. So some of the things that those of us who have medical providers linked to the CACs, again, sort of talking about that consulting role, we also always encourage the investigators to call the medical provider at the CAC before coming down with the child. So in my experiences, like I said earlier, a lot of these kids don't necessarily need to be seen urgently. And so going to an emergency department at a hospital is not always going to be beneficial. You're going to see an emergency room physician or nurse practitioner who does probably not have extra training in terms of child maltreatment, They won't be able to provide you with an opinion, especially around the causation of injury, and unless you're getting a sexual assault team, may not be able to provide all the sexual assault services that you may need with your case. Obviously, an emergency department is less trauma-informed and, of course, less aware of the process from a criminal point of view as well as a child protection point of view. And so, again, having a medical provider that's linked with your CAC that you could consult with to best determine the most appropriate location for that child to obtain medical services is really an important role. So I'm going to talk a little bit about sexual abuse cases and more specifically. And sexual abuse cases at CACs will be of what we call sort of acute in nature, meaning that the sexual assault would have happened within 24 to 72 hours of the actual sexual assault event, versus those cases where, which are not as urgent, where sexual assault or abuse have occurred days, weeks, or months prior to the disclosure or the investigation event. And one of the sort of basic standards that I think should be offered to all kids who come into contact with the CAC is that all children and youth should be offered a medical examination, regardless of what's happened to them and regardless of what the extent is. It should be something that's offered to all children and families. And this is even in cases of historical sexual abuse, where maybe fondling or touching and not penetration has occurred, where there may be anal contact and oral contact. And I sort of highlighted these only because I've often gotten comments about, well, you know, there's probably likely going to be no injury because the sexual abuse happened a long time ago, because there was only touching, or that there was anal or oral contact where there may not be evidence of injury. And while that may be true, the goal of the medical exam is not necessarily about identifying injury, but to provide reassurance. Many children and youth and caregivers want to be reassured following sexual abuse disclosure that they are okay and that they are normal. The purpose of the medical exam is really to reassure children and youth that they're okay, their body is normal. They also may have questions that may have stemmed from this abuse or assault. So questions like, am I a virgin? Am I damaged? Do I have injury? Will someone be able to tell that I was assaulted? These are really important questions that a lot of children and youth that I've seen have, and a lot of caregivers also have as well. So I think being able to address those questions one-on-one with a child or youth or a caregiver is really an important question. It may not even be that you do an exam, but having to meet with a medical provider to at least address these issues are important from a physical health point of view. The other purpose of the exam, of course, is to rule out that there aren't any injuries. So there may be physical exam findings, albeit rare. So the majority of examinations in child sexual abuse cases have little to no abnormal findings. So about 95% of cases actually have a normal or non-specific exam. There may be old injuries, however, that may be indicative of some form of trauma. There also may be things that may not be physically reported by children, such as certain sexually transmitted infections like genital warts, chlamydia, which may be asymptomatic, meaning that they may have the infection but may not have symptoms. And all of these need to be considered either through testing or examination to rule out anything unusual. So these are all important reasons why, even in the absence of potential injury, we may consider an examination for a child. We also want to consider possible STI testing. So a lot of kids and caregivers want to rule out that they haven't been infected by a sexually transmitted infection, and so very easily testing can be done. It's also an opportunity to review where kids are at in terms of their immunization status, For older females, obviously, who've been sexually assaulted, assessing sexual health issues as well, and for boys as well, birth control and harm reduction strategies when it comes to certain health behaviors. The other important element of the examination, it isn't the first one, but there are important sort of opinions that can be generated as a result of the exam that would be helpful from a criminal justice as well as a child protection point of view. It's really important that investigators understand that although the exam is normal, and there are no findings, doesn't mean that sexual abuse did not happen. This is also important for caregivers to understand as well. Many caregivers where children disclose do expect that there should be some kind of injury on the exam, but often, as I said before, that 95% of exams are normal or nonspecific, and therefore the general exam findings neither confirm nor refute sexual abuse concerns. And going through the reasons why that may be, both to the child, the youth, and the caregiver, as well as the investigators, I think is a really important role. There are many reasons why there may not be injury. One of the major reasons is that the majority of sexual abuse that occurs does occur sort of much later, the sexual abuse that occurs in respect to the disclosure, there's a bit of a time lapse typically. So if there were injuries, they may have healed. The second issue is around the type of contact that the child may have experienced. So it may not necessarily be full penetration of the vaginal area, and therefore injury may not have occurred. So contact may be fondling, touching, where injury may not have occurred. And so for a lot of these reasons, we don't typically expect there to be any physical findings. But just because there are no physical findings does not mean sexual abuse did not happen. And this is really important to reiterate, both, again, from a criminal justice point of view. And so having an examination, documenting the results, and having this kind of an opinion, I think is really important. In fact, the majority of cases that I do testify on is a result of the fact that there are no findings, and this does not mean sexual abuse did not happen. So that's sort of further down the list in terms of the reasons why we should do examinations for children and youth where there are sexual abuse concerns, but I think it's really important. So this is a case of a 5-year-old girl. She disclosed ongoing sexual abuse by her mom's boyfriend. The last contact with boyfriend was 6 weeks prior to the disclosure. Mom took her to the family doctor, and the family doctor reported that the vaginal opening appeared abnormally large and the hymen was not intact. So for some of you, this may be like, oh my gosh, this is so concerning. You know, this is physical findings, abnormal findings for sure. When we hear, so when Amy and I hear this kind of a referral from a family doctor, we don't jump up and down, but what we do need to do is probably have a look and reevaluate the findings. The majority of these kinds of abnormal findings that are reported are actually overcalling the findings, meaning that they're seeing something unusual that is actually very normal. And so when we get a disclosure, an investigation occurs, and a family doctor is reporting something unusual, this is a typical case where, yes, the child should be seen fairly quickly to explore the findings that the family doctor has reported. And this isn't to say that family doctors are not accurate or wrong in their diagnosis typically. What it does speak to is it is a very small subspecialty that if you're not seeing these kinds of cases on a regular basis, you're not familiar with the literature, it just isn't something that you're most comfortable speaking to. And so this is why when a child discloses and requires a medical exam, why it's important to really try and link with a medical provider who does have experience and competency in doing these kinds of exams. She was interviewed and then came down to the CAC for a medical exam, and her examination was actually normal. So the vaginal opening was normal, the hymen was present, and so that sort of reassured everybody that her physical exam is normal, but although she did have a disclosure that needed to be pursued by the investigators, it is important that a medical exam also be conducted to address the potential findings. Of course, we always explain the limitations of the exam, both to the caregiver and to the investigators, but in this particular case, I think it was really important to address what the family doctor saw, because that actually caused a fair amount of anxiety for the mother in particular, thinking that something may have happened or some physical injury may have happened. And so the importance of reassuring her that actually her examination was normal is important. So again, setting up sort of processes with your CYAC in terms of how to access medical providers when there is an urgent need versus a non-urgent need. So when we talk about an urgent need for sexual assault, we're talking about a sexual assault that would have occurred within probably 48 hours. So a disclosure and an event that has occurred. And what makes these kinds of cases sort of urgent, there's a couple of things. One is the need to collect forensic evidence. We know in young children that evidence can be a critical part of the case, and we do have a very small window from which to collect that. Evidence does diminish the longer you wait, and so the sooner we can see kids to help police to collect that evidence, the better. Obviously, if kids are expressing symptoms of pain or bleeding or discharge, we obviously need to address that much sooner rather than later. In addition, psychosocial symptoms, so if kids have disclosed and are reporting any psychosocial issues such as suicidality, self-harming behavior, those obviously need to be seen and addressed as soon as possible. The other urgency are the needs to start them on certain medications. So in acute sexual assaults where there may be injury or high-risk perpetrator, we need to consider providing HIV post-exposure prophylaxis or hepatitis B prophylaxis. And so these are both medications or vaccines that can be given to kids fairly quickly to help prevent HIV or hepatitis B. So again, based on the case, and every case is going to be different, not every kid will go on HIV post-exposure prophylaxis, but again, you want to have that assessment done sooner rather than later. And then finally is also the need for emergency contraception. So in females where there has been an acute assault, there is a small window, again, of about 4 to 5 days where we can provide emergency contraception in the form of a pill called Plan B. And this will obviously be needed, can be given, it can be provided sort of locally, but best to be done in the context of sort of a sexual assault evaluation. All of these things can actually wait to the next day. So we don't necessarily need to rush kids to a hospital emergency room immediately when a recent sexual assault has taken place. Although there are some communities whose police procedures or child protection procedure says that an acute assault, go to the nearest emergency department. Ideally, I would recommend that even in acute sexual assaults, if the child can be linked with the CAC and interviewed fairly quickly, then this can be done after the interview. Ideally, we want sexual assaults interviews to happen so that we're, as medical providers, not needing to interview a child and not needing to contaminate any potential interviews that may happen. However, if an interview cannot be coordinated, that obviously needs to be negotiated with and planned accordingly so that the most appropriate timing is thought of with respect to an exam and the interview. But ideally, we're aiming for an interview first, followed by an examination where many of these things will be able to be done in a fairly urgent way. So another case of a 12-year-old girl disclosed sexual abuse by uncle 3 days prior to her teacher. She was interviewed at the CYAC where she gave a full disclosure. we ended up bringing her to the clinic in the hospital. So the previous case or recent cases or urgent cases really need to be seen most often in a hospital-based clinic or emergency room with a sexual assault provider. And so, again, linking with your provider to help triage that case is going to be key. But in a lot of these acute cases, kids will need to be seen in a hospital, not likely in a advocacy center. So what we would do in these kinds of cases, we would bring them to our clinic in the hospital. They would be able to receive all the medications and then have further follow-up the CYC, either from a medical or mental health point of view. And so really linking with a hospital-based service is really what's going to need to happen with a lot of these cases, especially on an urgent basis. So that's the sexual abuse component. Certainly for historical cases, again, the urgency for kids needing to be seen is not a priority from a medical point of view. And so often it's just linking with the investigators, offering an exam to the child or youth and caregiver, and then booking that child in for a general sexual abuse exam. I find that the majority of those kinds of examinations can be done at a CAC clinic, or where you don't necessarily need access to medical interventions or medical testing or other services. When you're most likely not going to be doing STI testing, you don't necessarily, obviously, aren't going to be giving out medications or doing any other forms of testing, then those can, and it's mainly around reassurance of the examination and of the child, then those can be done probably in an outpatient or in an off-site co-located CAC. But again, that's going to be very dependent on who you have linked with your CAC and what the services are that are going to be required. So I'm going to pass it to Amy, who's going to talk about physical abuse cases, in particular bruising and skin injuries.
Hi there. So just waiting for this to switch over as I'm now the presenter. I'm just waiting for the slides to appear. Sorry, I'm just not seeing the slides up on my screen. Okay. Super. So I am just going to be talking about the assessment of physical abuse cases, and similar to the sexual abuse cases that we heard from Tanya, the first step really involves some triaging and for persons involved in the investigation to understand what a consultation with a CAC can bring or help bring to the case investigation. So the first thing that a clinician can provide for you at a CAC, whether it's a family doctor, pediatrician, nurse practitioner, documentation is really one of the keys, and so that would involve documenting any and all types of skin markings, and those might include markings that we believe are or have resulted from physical trauma, or such as bruise. There may be other physical markings such as a burn, which can also be documented, and there potentially may be other marks on the child that would be a birthmark or a non-specific mark that may have been traumatic in origin, but unlikely to be related from physical maltreatment. And that would come down to the expert opinion. And so once skin markings have been documented, they're part of the role of the medical personnel is to provide an opinion as to whether or not they are inclined to believe that the marking that they're seeing is either from an accidental mechanism, so something the child may have incurred just from running around and being a child, or whether or not it was something that more likely is inflicted. And I'll go through a little bit about some of those elements as the talk continues. Some markings that we see turn out to not actually be injuries. They may be a birthmark, they may be a marker or some type of dye or paint, as we have seen, and so it's not a traumatic finding at all. And that would bring us to sort of the screening for other medical conditions that can be mistaken for bruising. And the other part of any type of assessment for physical child abuse is to determine whether or not other investigations are needed. So, for example, in very young children, typically under the age of 2, we would give consideration to whether or not a skeletal survey would be needed, and that would consist of x-rays of basically all the different bones in the body that would need to be referred to a hospital that had capacity to do that. We may also, depending on the scenario in front of us, recommend that head imaging be obtained, whether that's a CAT scan or an MRI of the head, and possibly an eye exam looking for retinal hemorrhages and other potentially traumatic findings to the eye. And oftentimes, again, depending on where the injuries may be on the child, we may suggest some laboratory tests looking for abdominal trauma, which sometimes can be hard to detect just looking at the child. There may be some evidence that there's been some injury to the deeper structures of the abdomen. And health implications for the child, really, I mean, if you're seeing someone who has recently come into care with an injury, you may be able to identify some longer-standing medical problems that perhaps have not been addressed. And I myself, as a pediatrician, when I see a child in my capacity as a child maltreatment pediatrician, it's difficult for me to shut off that part of my brain that would be paying attention to things like development and whether or not, say, the child was wheezing or had other medical issues going on. Dentistry is another big one, and so it would be an opportunity to really have a thorough assessment. And if there were other medical issues that I could address that were sort of a quick fix, or that needed other referrals to, say, to another consultant to help with that, that's certainly something that can be done. And so just to come back to bruising being one of the most common findings that we see in terms of physical injuries from child abuse, it's caused really by leakage of blood out of the blood vessels into the surrounding tissues. One of the things that we would often consider when we see a child who has lots of bruises on them is whether or not there's an underlying predisposition to why that child is presenting with so many bruises, and whether or not that may be a bleeding condition that they were born with, or a medical condition that the child was experiencing at that moment that was leading them perhaps to become more vulnerable to bruising with less force. One of the take-home messages, I think, is that sometimes non-medical clinicians may have an expectation that if you bring a child to a physician or a medical clinician, that they will be able to date and time a bruise for you and age it. And if we could do that, it potentially would be very helpful because it would provide a really important hook for investigators in terms of when an injury may have been incurred. The truth of the matter is that we're not able to do this in any reliable way. There are some findings on physical exam that we can look at that may help us think about skin trauma and whether or not it may be acute or older, and that would be whether or not there's pain when we examine the child, if it's swollen, or if it's tender when we examine a child. But again, these aren't exact parameters or exact characteristics, and the color changes that a bruise goes through will be based on a number of factors, including the child's own skin color, the depth and the location of the bruise, and even bruises that are sustained at the same time in one person in two different parts of the body may progress through a color change or healing in very different ways. So if you receive that type of opinion or information, I would suggest that you take that with a grain of salt at a minimum, because the opinion may have been overstated in terms of what that person is able to commit to. In terms of when we see a child with bruises, you know, what is the framework that we use to decide if we're concerned or not? And it really comes down to three kind of major features of the bruise that we're seeing. The first is the age and development level of the child on whom we're seeing the bruising. So if you have a child who is non-ambulatory, so not mobile, not moving around, it would be very, very uncommon to see bruising on this type of individual. The fact of the matter is that when kids increase in terms of their mobility and they start cruising on furniture, they're more apt to fall, they're more apt to sustain bruising. But again, this sort of newly mobile population or population with emerging mobility will or should have less bruises on them than, say, a 5-year-old who's out playing on the playground and riding bicycles and whatnot. So as the child's mobility increases, so too we become more comfortable with seeing bruises on them. Certainly, another take-home point would be if you see a child who does not have mobility and you see a bruise on them, that bruise requires an explanation and a real fulsome understanding of how it got there. If there isn't one, then certainly maltreatment needs to be taught in people's minds as to how that bruise may have gotten there. The other factor that we consider is location. And so there's a lot of published literature and just in our own clinical experience that allows us to reason that when we see bruises on kids, there are some locations that are less worrisome than others. So for example, skin that overlies bone without a lot of soft tissue underneath it. So if you think about your shins, there's not a lot of padding there between the skin and the bone. These are high-risk areas for bruising because the skin becomes crushed when there's trauma to the skin, and bruising can occur relatively easily in those areas when compared to an area such as the buttocks where there's a large amount of soft tissue, and it would take more force to traumatize the tissue in that area to result in bruising. So there are certainly certain parts of the body that we would consider to be more concerning for findings of bruises. And this would be even in kids who do have mobility. So even in a child who is running around riding a bicycle, it's still uncommon to see bruising on the buttocks. It certainly can happen accidentally, but we would need to think about it really with some caution and with some thoughtful process in terms of the context in which that bruising had been identified. And the third feature that we think about is a pattern, and that's really whether or not when we look at the bruise, we can see either a shape or an outline or something that just is beyond just sort of like the non-specific, not well delineated bruise that we typically see when a child, you know, falls when they're running and they get a bruise on their shin. So you may see things that are suggestive of a handprint or bruises that are lines or bruises that wrap around different parts of the body are also concerning. So those are the three things that we're looking for. In terms of, sorry, the slide's maybe a little bit out of order, so I'm going to come back to that. I'm going to take you through a case here, and I'll describe to you the findings that were seen on physical exam. So this is a 7-month-old girl who her mother received a text message from the daycare provider saying that the baby had a mark on her face and that the baby had hit herself with a toy giraffe. The mom was worried about the extent of the injury when she picked the child up from daycare, and there was more bruising than she had originally surmised that there would be when she received this text message. So she took the child to the hospital. From there, again, because of the extent of the bruising, because it was a 7-month-old, still pretty young, has some mobility, but is not, you know, up and about playing soccer and riding bicycles. And from the hospital, a report was made to the Children's Aid or to the Community Child Welfare Agency, and a joint protocol for investigation was initiated. So it turns out there had been 2 previous bruises in care of the babysitter. There had been a bruise over the left temple the previous week, and the mom had told the babysitter had told the mom at that time that the babysitter had been carrying the baby, and the baby pulled open the door and brought the door into the side of her own head. And there had also been a bruise on the cheek recently, and the story for this bruise was that the baby had hit herself in the face with a rattle. So a medical history was obtained. There were no other, concerning features or past medical history in this child that would make one worried about a bleeding disorder or the fact that there may be a medical illness in this child that was causing her to bruise. So again, these are some of the tests that I talked about earlier, and because it was a relatively high-risk situation with a young infant who can't tell us what happened, a skeletal survey was done. So these are the x-rays of the entire skeleton, and there were no additional injuries that were uncovered. She had some blood testing to verify that all of the blood cell counts and the parameters that are needed to ensure that she didn't have a bleeding disorder were in order. And those tests were all normal as well. So we were able to take that off the table. And she also had some head imaging done. And again, this was because of the bruising on her face, because of the history of the prior bruising to the head and neck area as well. So there was a collaboration really from the beginning with the investigators that work out of the CAC, the investigating officer, and other team members gathered around and were discussing the case. This was the giraffe that allegedly the child had hit herself with. The investigators took measurements of the toy and they weighed the toy. The DVD of the interview with the babysitter was viewed just to clarify the details of the injury event. So this was really the team trying to get the best possible understanding of the explanation from the caregiver to help them decide whether or not this was an acceptable explanation or not. And at the end of the day, it was felt that based on the bruising that was observed, and I should describe to you what was seen. So she had some bruising that was not only on the side of her face, but also onto her ear as well. And there were some linear, so lined markings that were able to be appreciated within the bruising of the cheek itself. And so that was concerning for application of force with an object, and it was felt that this object could potentially be a hand. And so based on that and bringing together all of the information to the table, so the piece from the medical exam, the piece from the investigators, the DVD retelling of the story from the caregiver, it was felt that the explanation provided did not adequately explain the findings on physical exam of the child. Also concerning was a past history of 2 prior bruises that had been identified on this baby when she was in the care of this caregiver. The home daycare ended up being closed, and to date, no criminal charges have been made. And it was a really good example of how the investigators were able to collaborate with the medical process. And I think what's important to stress here is that the collaboration occurred in real time, and it was simultaneous. So as the investigators were gathering information, the medical exam was occurring, and then those pieces were brought together. So it wasn't like the police proceeded independently and then, months later decided to get a medical opinion so they could take that medical opinion to court. It was done in real time, and so it allowed for some really good information sharing and what we think is the best possible outcome for the child. So that's just an example of one type of case that may be seen at your CAC. That case has a little bit of overlap in the sense that this child did have to go to hospital for some medical testing, but certainly, you know, was a child who was well-looking and had bruises that needed to be documented. It was at that time considered to be appropriate for the child to come to the CAC and to have those marks documented and have the initial medical examination conducted. And sometimes you can't tell which way a case is going to go, and ones that you think, you know, maybe on the phone didn't sound as bad, and then they show up and then the bruising is quite dramatic. And other times you may be described over the phone that bruising is quite dramatic, and then you see the child and it's really, you know, not as impressive, or there's minimal skin injury that you see. So it is hard to tell sometimes over the phone when you're playing that consultative role that Tanya was talking about originally. So in terms of some logistical issues and challenges that you may face at your CAC, you know, there can be some injuries and there can be some issues, and some of them were highlighted in this case. But for example, generally speaking, you know, there may be issues about how to get a child to the hospital. So if a case comes in and the child is at school, depending on the purview of your own Children's Aid Society or community services organization, there may be some obstacles to overcome there in terms of who can transport the child to the hospital. And it also will depend on if the child is named a potential offender, because that offender would not be welcome or not be eligible to attend at the CAC. Sometimes, you know, teams struggle with when there's an outcome of someone not being charged. And I think the more teams work together, it allows the people who are not part of that decision-making process in terms of charging or not charging to better understand how those decisions are arrived at, because it can be surprising at times when you think, why wouldn't they have charged that person? It was fairly clear. But the laying of charges and the decision to lay those charges is based on a whole other set of criteria that are not always accessible to the medical providers. But if you start working alongside of law enforcement and crown attorneys, it gives you a better appreciation of the complexity of trying to make those decisions. And the other problem that I think most people struggle with, and it's sometimes even at the end of the medical exam, we're left with saying, well, you know, the story sounds reasonable, but you want to be able to come to an opinion that has a certain degree of certainty to it, and that's not always possible. And so sometimes, you know, you're left with that degree of uncertainty that you have to live with. But I think if the steps for the medical evaluation are done in a coordinated and in an organized and consistent way, and the opinions are consistent, that sometimes is the best that you can do. And you can only go so far with your medical opinion that you can't say something that you couldn't support in court for sure. And you need to be objective in your assessment. So I think I'm just going to pass this back over to Tanya at this point, just to talk a little bit more specifically some of the challenges and some of the successes that they have had at Boost specifically.
Okay, so I thought I would share just some of the outcomes and the benefits that we've encountered here at Boost. We've been open for about 3.5 years. We see a couple hundred cases in terms of the investigation and have provided medical evaluation in close to about 150 cases per year. And what I have found as being sort of the main, so I provide sort of the main medical consultation and provide direct service for sexual abuse cases, and then provide some consultation and triaging of physical abuse cases, and work pretty closely in collaboration with our pediatricians on our team to help to determine when and if a child needs an exam. So with the sexual abuse cases, I find that even in an investigation is occurring, I may take an opportunity to at least meet with the child in youth or the caregiver to at least offer a medical exam, to talk about what a medical exam would entail, the benefits to it, and I find that it gives them sort of an opportunity to ask some questions and then make a sort of an informed decision as to whether or not a medical exam would be beneficial. I also have found that, especially with adolescents, being able to actually meet with them face-to-face, to offer an examination, to talk about what an examination would entail, to do a little bit about sexual health teaching in terms of sexually transmitted infections and birth control, has really been, I think, a good outcome that I'm not necessarily sure I would have had the ability to do on a regular basis if I wasn't co-located with the investigators. In terms of the physical abuse cases, there's certainly increased consultation, so investigators are calling sort of myself and my team much sooner for collaboration around cases. We've been able to encourage investigators to take photos of children's injuries so that we could have a really quick look, attach sort of what the story is and think about any other risk factors, and then make a fairly good informed decision as to whether or not that child should have an examination by our team at the hospital and how quickly that should happen. So I find that that's been definitely improved in terms of a medical provider making those decisions versus a child welfare worker or a police officer making decisions as to whether or not kids have been seen. We've had a couple cases where kids may have a minor injury on their face. They have made a disclosure, and based on the disclosure and the injury and the age of the child and some of the red flags that Amy had outlined earlier, we would recommend that that child come down, only to find that there's more injuries, both old and new injuries, once that child does have a full physical exam. So I think that there's been some cases where typically those injuries may not have been assessed or seen or identified, and we're really pushing it a little bit more now. Our threshold at our SCAN program or our child protection team is pretty low for examining kids, meaning that we're pretty open when there's been any kind of disclosure or concern where there's a potential injury to see those kids. I've also found that there's been sort of general increase in consultation and sharing of ideas around how to address potential medical or developmental concerns at our case reviews. So often we'll have case discussion or case reviews where there may not have been consultation with a medical provider because there wasn't sort of an immediate medical concern, but in discussing the case in more detail, I become aware of sort of maybe a lack of a primary care practitioner, maybe some developmental issues that sound like they need to be further assessed. And so I can often recommend referrals to pediatricians either in the community or at the hospital to get some of those medical issues looked at in a bit more detail. I find that families are being serviced much more quickly and that there's increased collaboration with partners. I try and do both formal and informal training with child protection as well as police officers on sort of the red flags, what to think about in terms of medical examination, medical physical injuries. And so I think that there's just an overall sort of more thoughtful sense of these cases in terms of examinations and providing examinations. There's also better sharing of information among all partners. Now that could be a good thing or a bad thing, but I think the ability to obtain consent from the families at the very outset of the investigation and to be able to share with partners allows for better planning for different stages within the investigation and provide input on different elements of the family, either health care or mental health care as well. So some of the sort of unexpected things that we've run into, I have obviously wanted to be able to provide sort of a much more comprehensive service at the CAC versus the hospital. So if kids are being interviewed at the CYAC and all the services are happening here, the ability to be able to provide further interventions at the CYAC has obviously been limited. So don't have access, given where our CAC is located, we don't have access to certain laboratories or x-rays. You know, we are starting to explore a bit further in terms of, in particular, STI testing here at the clinic. The issue around confidentiality, still, while I sort of raised it as a positive element, it's obviously when you're talking about children and youth private health information, there needs to be some good containment of the information that gets shared. So the consents that we share are really based on medical information as a result of the sexual abuse or physical abuse investigation. It really doesn't go beyond that, and so it's very easy when you're working in a co-located model to maybe share more information than you may be realizing because you have the team all together. So I have had to be really careful around, you know, maybe knowing more about a child's medical information or mental health information, but being careful not to share that without proper consent from the child or the family. We've struggled in terms of documentation. So my hospital in particular, and being at a co-located in a co-located area, they don't want me to have, so co-located area outside of the hospital, that my hospital does not want any written documentation of patient information to be at the center. And so we've really tried to ramp up our ability to have electronic documentation. I have remote access from the CAC to my hospital-based computer, but obviously there's various things like consents and notes that get written that we're still trying to map out a way to ensure that none of that private health information remains at CAC, but does remain electronically to the hospital. Ownership of medical records. So again, that goes to the issue around sharing of information. A lot of times I'll get asked, because I have access to all the hospital-based charts, you know, someone will say, oh, we understand a child showed up in the emergency department for an injury. Could you pull up their chart and see what they were there for? And it's being very careful, again, around boundaries of how much you can really be searching for information without proper consent or proper involvement in a case. And then sort of the ongoing issue, which may come across some of your CACs, is around various research activities and database developments and how much information can be shared. Private health information is always sort of, while it's great to have such a big multidisciplinary team, it does pose for some challenges around sharing of information. So in summary, cases of suspected child maltreatment benefit from a comprehensive medical evaluation. Collaboration is really important and critical, and really to call and consult with a designated medical clinician in your community is really what's key, and really starting to develop those relationships with someone in your community who could take on sort of a consulting role and perhaps a more direct service role with your CAC is ideal. And that's it. Below is our email. If you have any questions or want further help in sort of sorting out how to establish a medical provider to link with your CAC, both Amy or I would be happy to help you with this. We're pretty familiar with most of the child maltreatment pediatricians and physicians across the country. So if you are in a community and you're struggling with finding somebody, Amy and I could probably help either to link with a key person in a certain area of your province who could then link you up with maybe a more local provider. And that's all for now. Thank you.